Okay, everybody ready for our final panel? My name is Brian Hanley, and I lead the public sector practice at EdFX. This is our first Sequoia conference, so we didn't have the courage to join many of you in karaoke last night, but we are not new to the interoperability space. We've been at the intersection of regulation and technology for about 28 years, helping our customers, which include major payers, provider-led health plans, 31 states, CMS in the VA, comply with evolving standards like X12, FHIR, and NCPDP to modernize their business processes and better serve their members. So we're focused on tackling the most pressing challenges in healthcare data interchange, like consent and prior authorization, to empower our customers to use mandates as a modernization tailwind rather than a compliance burden. We're a proud member of the standards development community, organizations like WEDI, CEQ, and others. And along with, and after seeing the incredible work that Sequoia is doing, we look forward to participating here and in the exciting interoperability years ahead. So with that, I'd like to pass it to our moderator for our final panel. Thank you very much.
Thank you. Let's give EdFX a big round of applause. Thank you for the sponsorship. Oh, good afternoon. Welcome to Little FHIRs Everywhere. And thanks for hanging in with us till the last session, last panel of the day and of the conference. We appreciate your attention, and we'll try to make it worth your while. We're going to be talking about the expansion of FHIR and how TEFCA as a framework can ramp up the exchange. And I wasn't really the person that thought of the title for this session. And when I first saw it, I thought, not sure what that means. But the more I thought about it, the more it made so much sense to me that we're in that place in the FHIR roadmap where most of us, if not all of us, have at least dabbled in FHIR, maybe done a proof of concept, maybe doing some testing. But there's kind of these little FHIRs everywhere, right? Everybody's doing something, maybe just a little bit. Some of those FHIRs may be starting to get a little bit bigger, and we need to get them to come together. But it did kind of make sense to me that we're going to talk about what we're all doing with TEFCA, with FHIR, and how we see TEFCA playing into that role. I was going to ask how many of you are implementing FHIR now, but I expect most of you are. It may just simply be to exchange data between your own internal platforms. Maybe you haven't done anything externally yet. I know the payer I used to work with, that's where we started, using FHIR between our own data platforms. If you're doing anything with patient data, you've done some FHIR with the patient access API that we all had to comply with. Now we're looking at several other APIs that are going to be coming at us with CMS 0057, and we're going to talk a little bit about those today, specifically the payer to provider and payer to payer. So I'm going to start by asking our panel to introduce themselves, and if you could just speak a little bit about to why FHIR and or TEFCA is important to the success of interoperability as you introduce yourself. That would be great.
All right, I'll go first. Jason Vogt. I am the manager in development at Meditech for all of our APIs and structured documents. If you get anything FHIR-based or anything CCDA-based from Meditech, it came from my team. So FHIR, For FHIR, I think the big thing for us is, like, a lot of times when you talk about exchange now, it's kind of a push model and you have the data that they want to give you. And I think with FHIR, the main thing that we get is the ability to query for the specific data that you're looking for. You may be looking for a specific result, a specific clinical note, whatever it would be. So you're actually able to narrow down to potentially find that needle in the haystack that you're looking for. And you can maybe traverse a little bit deeper into the database as well, because if it's a specific one you're looking for, but it's 6 years old, you probably wouldn't get that in a document in most worlds. but you could be able to get that through a FHIR query because you can say, yeah, I want to go all the way back in time because I'm looking for this very specific thing, and then FHIR queries allow that to happen.
Hi everyone, I'm Bob Oakley. I am the strategy and interoperability lead for the Physician Innovation Group at Evernorth. That's part of the Cigna, one of the Cigna business units. We manage the PBMs, the pharmacy, and direct medical care teams as an organization. For us, FHIR is a means to accelerate the communication between payers and providers, provide a much better experience for the patient, and putting them at the center of the effort. And we're excited to see the developments in TEFCA this last year because we think to get this at scale, we're going to need a trust network to make it happen.
Hi everyone, I'm Michael Westover. I'm the VP of Data Partnerships and Informatics at Providence on the West Coast. And my teams have a few in production FHIR connections with our payer partners, and we're excited about that. And why I think FHIR is important to interoperability, I'll tell it through a story that I read recently that really resonated with me. I believe it was 1867, it was December, it was about this time, and there was a train that was going from Cleveland to Buffalo, New York. And the train in Cleveland, the rail line gauges were 4 feet, 8.5 inches wide. Now, the rail lines in New York were 4 feet, 10 inches wide. So there was a minor difference. And the train on that track was what's called a compromise car, meaning that when it was on the New York side, it would have a little bit of give as it was going. And while it was in New York, it hit a railway switch near a truss bridge, and the first class car jumped the tracks. And then the trains became decoupled, and the passenger car went down a hill about 40 feet. And there were potbelly stoves on each side of the train. And the one at the bottom, because it was inclined so much, the train, the potbelly stove at the bottom emptied, and then the people fell toward it. And then the potbelly stove at the top fell toward them. And so the people from the first class train got out, and they watched. And they couldn't see anything, but they said they could hear it. And one newspaper writer said that their screams died to moans and the moans to silence. And because of this catastrophe, there was a huge change in that's when a lot of rail line gauge standards happened in the United States, where everybody went to 4 feet, 8.5 inches. Also, the potbelly stoves went away, and there were safer ways to heat the train that were implemented. And I think that resonated with me so much because in my role, I have about 2,000 data sources that are flowing through my teams, and they're all different data. I mean, they're similar data domains, but the data is all structured differently. And when it's flowing through, if there's a problem, I hear about it. I hear about when a patient wasn't taken care of. I get a call that says, we should have known about this. Why didn't I get this data flow knowing this person needed an outreach? Or when the wrong patient gets called and somebody feels like their identity has been stolen, even though it was just the wrong information came through to the care manager that reached out, or we're not able to invest in a program that could help patients or move the system forward because the data standards aren't there. Data standards are a reasonable function of government, something that these public-private partnerships, it makes absolute sense, Republican, Democrat, even in a DOGE scenario, that we need to have.
Hey folks, my name is Nihit. I'm a technical solution engineer at Epic. I agree with my co-panelists here, and I think that was a really impactful story, Michael. I think in order for interoperability to be successful, I think there's 3 main pillars first to think about. There's standards for how to exchange data. There's governance to define boundaries on how and when you should be exchanging data for what purposes. And then there's a directory to help you understand who's actually available to exchange data and production ready. How do you exchange with them based on their entry? I think FHIR is really important for that first of the 3 pillars for standards. It's modern, it's lightweight, as we've heard from a lot of folks here. It's helpful in getting that exchange happening seamlessly. And I'm excited about how it continues to evolve our industry and interoperability.
Thank you. Those were all great answers. we're going to turn a little bit more inward for each of your organizations and just ask, what is your organization specifically doing with FHIR and why? Nihit, you want to go first? We'll start at the other end, Jason.
Sure, yeah, that's a good idea. So we're fully committed to enhancing and using FHIR in all of our interoperability tools, and we continue to develop our APIs and tools to help fulfill that mission. So today, we've developed and released almost up to 500 different FHIR APIs that are used by our clients and different vendors that they can leverage in their connections. I had to look, but we have 180 million FHIR resources used daily collectively across our organizations. So FHIR is very much real. It's very used oftenly in interoperability, and it's well adopted. And we did, just in August, release our support for USCDI version 3 FHIR APIs, which are 15 months ahead of certification timeline. So again, whenever new standards come in, we want to make sure we're able to meet those guidelines.
Excellent. We actually use some of those FHIR APIs, every day. So at Providence, the way we used to do things was in olden times, it wasn't that long ago, but we would have an analyst write a query for every single thing, right? And when it came to, let's say, sharing clinical quality data for HEDIS measures, that individual would have to go into the back end of our EMR and use 27 tables and then bring the data together and then package it up and then post it on a server somewhere for the payer to pick it up. And we do this with all different types of data exchange. And it was incredibly inefficient. The data wasn't as good as it could have been. If anything changed in the EMR, things broke. It was problematic on many different levels. So then we moved to a system where we pulled the data out of our EMR using some of the APIs that we just talked about in a native FHIR format. And when we did that, the amount of clinical data that we had to share with our payer partners increased by 40%. So that's not it didn't change what the providers were doing. It was just our ability to communicate what we had been doing. And it also put us in a position where the payers became very, very happy with what we were doing and started asking us, what are you doing? It instantly helped our relationships. I would love to talk to you, anybody who's interested, about the process of how that works, the technology. But another way that, and we're trying to do this across all of our data domains and data exchange. And we're sharing that data with 40 payers right now, but only a few can accept FHIR. So what we do is that we collapse that FHIR down to a flat file that the others can receive, and they can still get the benefits of the better data, and then we can work with them to get them to a place where they can accept the FHIR and get all the benefits of end-to-end FHIR and the rapid implementation of that. One more quick benefit is FHIR implementation prevents data standoffs. So when I sit in a room with payers, my friends, I look across the table and I say, we want you to use our standard data format. And they say, no. We want you to use our data format. And then they talk about how big they are and how they have so many clients. And then we talk about how big we are and how important it is to them. And then we have this argument, right? But when it comes to FHIR, the conversation changes because we say, we are using a data standard. And we would like to use that national data standard. You don't just need to use it for us. Start using it for all of your other provider clients. That's where they're going right now. Let's partner together and do something big. And if they say we want to use our data standard, not FHIR, we then say, what standard exactly is that? And they say, oh no, it's just our proprietary standard, but we're so big. And that conversation goes really well. So I think FHIR is a nice way to create that connection.
Yeah, and that at Evernorth, really to echo a lot of that and to build off of that is that the reason why we see it as an accelerator is because it takes all the complexity of mapping different data sources, normalizing data, and puts it into a structure that then we can replicate very rapidly. So at Evernorth, all of our internal communication connections between our lines of business, like if the pharmacy needs to share data with the PBM, all of it is done through FHIR. And as we're looking to engage more into the marketplace and exchange data directly with providers, we try to go FHIR first and then fall back to wherever the market is at the moment. But it is an absolute value generator for the organization, again, because we've removed the need to figure it out from and moved it to let's solve the problem we're trying to solve instead of the problem of trying to solve getting the data to support the problem. So it's been a really fantastic tool for us.
Yeah, Meditech, I guess just 'cause I was talking with Ryan earlier today, like we actually don't make any AIHE transactions across any network. We actually are FHIR based across the board. So from day one, when we were in Commonwealth, every transaction we make to us or into the network is a FHIR-based transaction. We share documents over document reference. So we've been doing that for a very long time within the networks. And then, I guess just to one up a little bit, we released our US CDI last year at this time, and actually have our US CDI v4 ready for production now. Well ahead of even being in a regulation. But no, I think, to Michael's comments too, right? Like a lot of times when we're having conversations with our third-party vendors, right? Like if they're like, oh, I have this proprietary API thing, and I'm like, okay, cool. I'm not doing that. Like it's either FHIR and we're going to be agnostic, or we're not. Like we'll work for somebody else. And sometimes it's a little harsh to tell them that right away, but they all kind of understand, and then they usually. Next call is like, yeah, I think we should do this FHIR thing. That sounds great. And then for the rest of the other things we're working on, we have the International Patient Summary, Da Vinci, burden reduction IGs, working with the enhancing oncology model and Codex and M-Code for those types of things. And we're just trying to see where we can fit in a few different things. And then, when we talk about TEFCA, right, we did a lot of stuff with FAST right now, trying to figure out how to bring FHIR to scale. The FHIR security work group, or the FAST security work group, and that IG that we've published from there, going to version 2 for that. There's just a lot of things on that scalability side that have really been, Meditech has really been trying to help and push across to everybody, so we can really try to scale that FHIR.
Jason kind of led us into the next question, so I may skip you, or if you have something to add, that's fine. But what are some of the challenges to scaling FHIR beyond where you are today to where you want to be?
I'll go last.
Well, I mean, for us, the challenges that we're seeing is, it's the point-to-point nature, right? That you pick a population and you pick the provider organization that supports that population. And we get in a room 6 months of banging back and forth on DUAs and particular contract language, and then 3 weeks after the contract signed, we're testing our first FHIR connections. Right? It's not the technology, right? It is the trust and the policy and the standards that are starting to align is going to help us accelerate it. But right now, it's little FHIRs everywhere.
Is it also partly about the rest of the industry being ready? Or is it more about the need for that trust network or highway?
Well, it's both, and I thank you for challenging me on that.
Okay.
Nancy does this often. She's a fantastic mentor. There are parts of the network or the marketplace that just don't have the investments, or relying on a vendor or relying on a partner to do this work for them, and so they haven't done the internal work. I just talked about the mapping. The reason why the mapping is so fantastic is because of 9115, we invested significant resources in mapping every data source in the organization into a standard. That you can't cram for that, right? That's got to be something you got to do up front. So that is a limiting factor in the scale, but again, it's not technology. It's nobody has to invent anything to make this happen. It's just a matter of we need to get prioritizing these types of connections in the industry.
Yep, bringing those little FHIRs together. Michael, what kind of challenges do you see with scaling FHIR farther than we have gone today?
Yeah, the two big ones for me are uncertainty and misunderstandings. So what I mean by uncertainty is there's so much that's changing in this environment right now, and so many new rules and regulations and different parties and market dynamics that are happening. Sometimes it's hard for folks to know, what do I need to do? What is my EMR going to do? Like, how is the TEFCA framework going to evolve and the adoption, and what are the payers going to do? How do they want to evolve? And we have all these different, and it just makes it hard to find partners. And then on the misunderstanding front, I talk to a lot of providers and a lot of payers, in my role, and I hear things that just take conversation and understanding. Things like, I can't do FHIR right now because I need to rebuild my entire cloud infrastructure. And then after that, I'll be ready to do FHIR, right? And that's just frankly not true, right? There's so many ways you can start with FHIR. They might say, you know what, I can't do FHIR because I don't have any willing partners. And I'm like, well, wait a minute, like, our team just moved to FHIR, and even if we had no one to catch the data, we improved our data by 40%, which is a massive, meaningful impact for our patients and for the business. So I feel like there are these small understandings and then the uncertainty, and that's, the more clarity we can get, the more I think people are gonna jump on board. Sometimes there are also a few situations where they just don't know what the solution is for providers right now. Like, what is my option? I know I can see one option, I would like to have another. How can I have a seat at the table?
Sounds like some opportunity for someone, Mary Ann, to talk about how do you get started with FHIR? You know, for all those folks that could learn from you all that have done a lot of work with it, and to answer some of those questions you're talking about, Michael, to say, you know, you can get over that barrier, and here's some options you have. So thank you for that. Nihit?
Yeah, I think I'm going to agree with a lot of what you all have said. Start with a technical challenge, more of a technical answer. I think when you look at FHIR at scale with a network level, you need technical trust. You need to ensure you know what the clients are. You need to ensure that the clients are vetted when they're onboarding and registering. UDAP is good, right? It allows auto registration of the clients, but with that, you need to ensure that those applications are trusted, and what happens if one of them has a cyber event, like we just talked about in the last panel. So I don't think there'll still be a need for the trust mechanism, whether it's certificates or something else. I think Sequoia has done maybe just getting an update yesterday about the plan there, so more to come there and more evolving. That being said, technical work is grunt work. It takes time, but it's very solvable. I think the more challenging elements to what these gentlemen have mentioned is the policy work, ensuring everyone's ready, ensuring there's a buy-in, ensuring there's standardization, and there still needs to be continued work done in that space.
Yeah, and then I think for me, right, I think we've started to solve some of these problems that you guys are mentioning. And I think now it's where the technical and the policy are starting to come together, right? Like, we have the TEFCA FHIR workgroup, and I think that's where things are starting to come together, right? Like, we have a security IG that we can use to dynamically register clients across the network. Okay, is that good enough? I think we're at the testing threshold now. Like, we need people to test, we need implementers to implement and start working together to prove that, like, the sandbox testing we've done at the Connect-a-thons is actually viable. And then the work group is also working through, okay, what else? Auditing. What type of auditing things do we need to do? What kind of reporting we need to do, right? It doesn't all go through the QHIN anymore, right? It goes point to point, and it's facilitated through the QHIN. So what kind of different information do we need to store or send back to the QHIN? Those are the things that we're really working on now to try to help push the industry to get this scalable solution. And I think now we're really at the time where, like, we need everybody to start implementing, ask the questions, ask the policy questions, the hard questions about how the heck do I use UDAP and SMART together? They say they're compatible, but, like, they're slightly different here and slightly different there. And those are some of the questions that are starting to come in now because people are actually starting to implement that. Epic is a good example of that. Like, they've asked a lot of good questions. Some questions are a little bit tougher than I'd like them to be, but we get to the answer. And I think we're at that tipping point now where we're really at the, like, implement, test, and, like, does this work? And if it's going to work, now is the time for it to happen.
Well, thank you all. I'm going to take us a little bit more specific now. Our last topic is going to be TEFCA, so hold on for a minute. But while we're still on FHIR, we have CMS 0057F looming out there for all of us that we're going to need, that we're required to use FHIR to do transactions between payers and providers and payers and payers. So I'd just like to ask each of you specifically talk about what your organization's doing Michael, I know you're going to be able to tell us a lot about what you've already done, but how are you seeing, what's your org doing for payer-to-payer, payer-to-provider implementation?
Yeah, I'll start. Right now, we're focused on the technical implementation pieces of it. I'm not part of that focus. I just get to reap the rewards of that hard work. But we're involved in a lot of the connect-a-thons that are happening now, as Jason was saying, testing it out, making sure things are working. But it's 2027 is coming fast. 26 is right around the corner, and so we're using all of that time to spread that development out. But it takes time. These things do not. Once the first one happens, the second and the follow-ons happen quick. But these first ones take some time. We're going to have to iron a lot out.
And I think we get experience with, maybe testing and working between, to Michael's point to point with a particular payer. You may have another payer you may have a relationship with. Yeah. We're going to switch gears in a minute and talk about TEFCA, but also scaling payer-to-payer and payer-to-provider to all the payers and providers that are out there is a huge task. So, but before we get there, Michael, what's your organization doing right now as it relates to those two?
Related to payer-to-payer and payer-to-provider. So I tend to focus on payer-provider as opposed to payer-to-payer. But we are working very closely with many of our payers on, and I'll tell you about one thing I'm excited about. Like the Provider Access API is huge because on one side you have, the Care and Blue Button claims data, right? And I get claims data in 60 different formats, like wildly different formats. Sometimes even within the same payer for the same contract, like multiple formats, right? And then on the other side, you have the clinical data, like PDEX, right, or USCDI data, and the Provider Access API combines those data files in a way that we could get access to basically everything that the payer knows about the patient. And the uses of that data are so exciting, right? That we're talking about there's the use inside of the EMR for the patient at the point of care is huge. And then if you look at the claims data for value-based care, being able to see everything that happened or clinical information that might not be available, like in bulk outside of the EMR, is huge too. So I think we're having initial conversations about how can we do this either through networks or point-to-point. We really want and need access to this data. Honestly, the patients are begging for it. The doctors are judging me because they don't want me to get in the way. Like, this is something that we need to get in front of our patients.
Thanks. Nihit, what's Epic doing to support us as payers and our provider partners in the new rules that are coming and specifically in adopting FHIR?
Yeah, I think it's a good question. And for folks that were here at the eHealth Exchange conference, I think you were talking about CMS 0057 rule there as well. And I think there were some really good questions being asked by the audience about how painful it is for providers to go through the prior authorization process. And I think when we talk to payers, they also tell us they want this process to be streamlined because they need the information on their end to be able to do prior authorization quickly. So I think I'm excited with Da Vinci's help about the new specifications coming with CMS 0057. I don't know if that's how you say it, but from Epic perspective, we've already supported CRD. We're planning on supporting the other two, DTR and PES, by early 2026, because we do believe in ability for our providers and our payers to work closely together, creating a more seamless experience for prior authorization, helping both the patient and the provider.
And I'll just jump right in because we're actually, people don't know this, but we actually meet with Epic like every other week about burden reduction to try to make sure that we as EHRs can actually implement that IG and help inform the community and kind of show a united front of how this can and cannot work for the EHRs. So that burden reduction piece, Nihit mentioned the 3 IGs, that's very important to us too. We're kind of on similar timelines. We're trying to get that out here in early 2025, at least for some initial testing. And then for the other payer data, right? We're hoping to look at that as another data source for clinical data, right? So to help with treatment and those types of things, but also for claims, right? We mentioned claims a lot. If we can learn what we're doing wrong when we submit the claims, we can fix those and we can save more money. So We want to still see how we can do some of that claim adjudication, learn better on how we submit the claims, what went wrong when we submitted those claims so we can fix them faster. And those are some of the advanced topics I think that we can also utilize these payer to provider exchanges for, is to help that claims process and help reduce the burden on that side as well. You know, we got it authorized on the front end, we got to, you know, submit it on the back end, and I think there's a lot of things that we can do there that our revenue cycle team is really after too there on the API side as well to help with that claim process.
Yeah, I love where you're going with that, because I have a passion around the claims process itself and thinking about us moving to value-based care. And, you know, we have a very traditional claim system that we've had forever, but with value-based care, it could look a whole lot different. You know, the reasons we get claims and are changing, and what we do with claims is changing. So I think you're spot on. I think there's a really frontier there to do some industry innovative things around claims and claims processing. We have about 10 minutes left, and I want to spend that time talking about TEFCA. So we've heard a lot about it in the last 2 days. We've heard folks say, well, it sounds like a great thing and it's just not ready for prime time. We know it's not ready right this minute. But I would love each of you just to talk a little bit on your thoughts on TEFCA, where you see it playing in the ecosystem, how you'd like to see it go, and if there's any way that it would fit into the future plans for your organization.
Yeah, so for TEFCA, I mean, I think it's a central portion to our strategy with FHIR. I mean, I think the way TEFCA or any network is aligned right now is that, like, once we can solve the registration problem for a client, every FHIR use case is open, right? Now, there are some technicalities on each use case, right? If it's a patient trying to access it, they need to know how to authorize. Are they authorizing through the portal? Is it authorizing through a federated identity, digital identity? There's a lot of different aspects to that, but from a, can I get from my client and make a query to this server? Like, once we solve it once, we've basically solved it for all use cases. Now we just need to iterate on that and say, okay, how do I know if I'm trying to do, you know, get information for, you know, treatment, as in, like, they're here and I'm trying to treat them, or I'm trying to figure out that I have a referral and I want to go book an appointment at another organization, right? Each one of those has some technicalities on, like, what the directory might look like in those different things. How do I find those endpoints? Those types of things, which still need to be ironed out, but, like, we would have the ability to do that registration for the client and get them access to the data that they're looking for on the server. The scopes would be figured out, the registration is figured out. So, like, it can be very powerful and it can go very quickly. And I think that's where, like, I am most excited is, like, I feel like we're on the cusp of that testing and that, like, big bang explosion of, like, FHIR at scale in a network. And we have, like, I would say about a year of testing and, like, massaging of the workflow, and we're ready to go for that big bang.
Yeah, but for us, putting the patient in the center of it. You know, when we look at where there are points of friction in their experience today, right? Prior authorization, aggravating their physicians with requests for data or claims data that's 6 months old being used to tell them what they might have been able to do better 6 months ago, but no insights on what might be a need right in front of them. All these things get solved with data and changes in workflow, right? A lot of our workflows are designed around, we don't have access to data, so we have to go get it. With TEFCA, the opportunity here to really transform that experience, be one where the patient is at the center, where their data follows them wherever they go and is available for the person that's treating them in the moment. I'm literally I'm such a nerd, I'm getting goosebumps just talking about it right now. But this is so important to do well and to get right. And we're gonna stub our toes and skin our knees along the way, but it's okay, because every step we're making this past year has been fantastic. I gotta spend a lot of time educating people back home on, no, things are really moving forward. But it's starting to happen, and it's very exciting.
So I wish I had been counting the number of times I heard the word trust during this conference. Like it's a massive number. I think when we talk about trust and the trust exchange framework, there are really two different definitions of trust that I think we're commingling. The first one is the trust framework, like the technical environment and the policies and the exchange purposes. And it's incredibly important that we have trust in the network. Like we need that trust. But then there's also trust between the parties that are connecting within the network that are equally as important. And there's actually a lot of research around like how to build trust with another human being. Harvard folks study it, and Stanford folks study it. And we've tried to implement some of those strategies within Providence, and we found it to be very successful. Or we did some things that didn't work, and then we tried and we researched. And I'll give you an example. So we will sit down with a payer partner, or maybe it'll be on the phone, and we'll do an outreach, and we'll say, we would like to work with you. Like that outreach of like, we want to make a connection is important. And then to say, we actually think we have a shared vision. We have a value-based care contract where we're jointly sharing like risk on a population. Like let's work together on doing that. And then sometimes it could be like, no, we don't have time for that, and that's fine. But very often it turns to, all right, what do we need to do together? What do you need, payer? And then the payer says, what do you need, provider? And we talk about a balanced reciprocal relationship where what data needs to flow to the payer to take care of these populations? What data needs to flow back to us? We also talk about like not overcommitting and doing too much, because delivering is really important to build trust. There's also to not go too fast, that you kind of miss each other and you can't communicate. Trust actually happens gradually, according to the research, right? And then after you have that trust and you start to deliver, you can build on that, right? And I think there are huge opportunities to build on that through like state collaboratives, through TEFCA and these types of organizations. And we feel like, I mean, my feeling is that when it comes to relationships and connections with payers specifically, there are a few organizations, let's say 10 organizations, and they can include important vendors that are incredibly important to the success of Providence and any providers like that. And we need to have a strong personal relationship with those organizations, absolutely, to be successful. Through what we talked about. We need to build that trust together and maintain it. And then I feel like there's a long tail of organizations that we won't interact with very often, but then still need the data, and we might need data from them to help our organizations. And I think we can lean heavily on the trust and the trust framework and maybe less on the relationship. Of course, we'll need to have trust in the trust framework across the board for everybody. But I think we also need to very much emphasize the point-to-point relationships in that.
Yeah, we, in the organizations I work in, we talk a lot about that long tail. The long tail for payers is all the EMRs that we might have to go connect to. You know, there's 4 or 5 that have a majority of our membership, but then there's 200 that have somebody somewhere, right? But it's the same for the providers. You have a payer mix that's not just 2 payers. A lot of times it's 20 or 25 or 30 payers, and you have some of those that are bigger portions of your pie than others. So there's a long tail there too. And one of the things that really keeps me interested and excited about the vision of TEFCA is very simply that single on-ramp. And that single on-ramp to solve that long tail. And I think that's what you're trying to say, Michael, and what you're talking about of the smaller partners that are important, but you can't go have that personal relationship with all of them.
Absolutely. Yes, you can have a relationship with all of them. And I think it's also really important for us to remember that when we're creating the networks, we shouldn't do things that create distrust among the parties within the network, right?
Yeah.
Because the way we design it has a huge impact on how the parties can interact within it.
I think also we have to think about the technology. And TEFCA has to be thinking about that long tail. We have a lot of folks up here, Meditech, Epic, Cigna, Providence, that have pretty sophisticated IT organizations, have been using FHIR for a while now, are ready to scale. But that long tail of both payers and providers is not there. So how can TEFCA help facilitate with other services or whatever it takes to get more of that tail to the single on-ramp, so that we're not just communicating between large health systems and large payers, but we're being able to move that down the ecosystem into the medium and small size folks that still need to meet these requirements and these rules, but maybe don't have the resources or are not as far along as some of the bigger folks. Nihit?
I think everyone here hit the nail on the head, and especially you, Nancy. We're obviously very deeply committed to TEFCA, and every time I listen to Mickey, I get passionate and excited about what TEFCA holds to offer, right? It's not just about treatment, it's other use cases that are well thought out and it's done appropriately. And I think it's right for the patient, as we talked about. I think it's really important to done with trust. To your point, Nancy, I think everyone in this room probably has already heard about TEFCA, and it already has a good idea what that means. But there's a large portion of the country, a lot of healthcare organizations, a lot of payers, a lot of other groups who are still in the dark of what TEFCA is. Why is it different? What value does it provide us? And what we've been really trying to do over the last couple of months and going into the next year, and we have a team who does a lot of legwork back there, is help stakeholders understand the benefits of TEFCA. What is different about it? Why do we believe in it? And I think that's really important for the trust factor to be there, so people understand what can TEFCA do for me and how do I feel comfortable exchanging over this framework.
And QHINs, we haven't mentioned that as part of TEFCA, but they play a huge role in all of this, right? What can they build out to help that long tail? Where can they support with services, even the bigger guys that may need something extra? How are they going to help us all be? First of all, I loved the dating game yesterday, the funnest part of the whole conference. But as fun as it was also very enlightening, or at least we should be thinking about how do we choose a QHIN, right? There's 7 options right now. There's going to be more. But how do payers choose a QHIN? How do providers choose a QHIN? So I thought that was really spot on as we're talking about how we're going to scale TEFCA, how we're going to scale FHIR. QHINs are going to be critical to that. And they're going to distinguish, we need to understand how they're distinguishing themselves so we know how to choose. We have just a few seconds left. We'd be happy to take a question or two if anyone has one. And I cannot see a thing with those lights, so just stand up and wave.
I just want to say the bachelors yesterday with their sunglasses made like the wisest choice ever getting up here with sunglasses. Really bright.
So true. All right, well, we really thank you for hanging around with us. Hopefully you got some good information and enjoy the rest of your day.